Hello everyone, my name is Krishna and today we are going to be diving into a very essential neurology topic, stroke localization. But before we get started, if you're looking for free guidance on how to excel in your USMLE preparation, like choosing the best resources, accessing customized study schedules, or learning strategies to ace each and every step of USMLE, make sure to sign up using the link above or in the description below. And if you're looking for personalized one-on-one support for your step 1 or step 2 CK, we have got you covered. Just check out the link below for more details on our tutoring service. So now let's get started with this topic, effects of stroke and stroke localization. I used to be absolutely terrified of stroke localization questions in the USMLE, such as this one here. It often made me wonder how neurologists manage to do this complicated thing. But then I realized that neurologists are so amazing that they've already laid a very easy framework for us to easily conceptualize stroke. So, no more memorization. Let's begin to understand the concept of stroke and how to localize it. So, stroke is a cerebrovascular accident. It is an acute neurologic condition in which the arterial blood supply to the brain tissue is impaired due to some focal vascular cause. Now, the ultimate cause of neuronal cell death is always ischemia due to insufficient perfusion. This insufficient perfusion, however, can result either from occlusion, resulting in an ischemic stroke, or the insufficient perfusion could be due to rupture of an upstream artery leading to a hemorrhagic stroke. Strokes can be broadly localized to either the cortex or the brainstem. Now, the cortical lesions present with focal deficits, like an arm weakness or a leg weakness, while brainstem lesions tend to show gross deficits, such as hemiplegia. And also, with brainstem stroke, you will often find crossed signs. Now, these cross signs are because, remember, most of the motor and sensory tracts, they tend to cross over in the brainstem. So, if the tracts are crossing over, of course, the symptoms will be on the opposite side of the lesion. We'll get into that later, but let's first tackle the easy peasy cortical stroke. So now the vascular supply to the cortex is by the ACA, MCA, and the PCA. Now check out this coronal section here and you can see the blood supply based on the homunculus. You can see that the anterior cerebral artery supplies the legs. So, if ACA gets affected, there is going to be contralateral paralysis and sensory loss in the lower limb, and also urinary incontinence because bladder is also in this territory only. Now, MCA has a huge territory, as you can see. This is supplying the arms, it's also supplying the face. So, of course, there will be contralateral paralysis and sensory loss in the face and the upper limb. Moreover, Broca and Wernicke, the two speech areas, they also fall in the MCA territory only. So, aphasia will be seen if there is stroke of the dominant, which is usually the left hemisphere, and hemi-neglect will be seen if the non-dominant or the right hemisphere is affected. So, that's about ACA. So, ACA will cause contralateral paralysis and sensory loss in lower limb. MCA, in the upper limb and the face, there will be motor and sensory loss along with the speech areas, Broca and motor being affected, leading to aphasia. Now the last one is the PCA. Now PCA supplies the occipital lobe where we have our vision center. So there is going to be contralateral hemianopia with macular sparing for PCA. For example, if your right PCA is affected, if the right PCA is affected, you will get homonymous hemianopsia like this when the right PCA is getting affected. Now, why is there macular sparing when the PCA is affected? Because the macula has dual blood supply. It is supplied by the PCA as well as the MCA. So even if the PCA is affected, the MCA will still be supplying the blood to the macula. So that is why when PC is affected, we get contralateral hemianopia with macular sparing. Now to tie it all together, have a look at this stick figure here at the bottom. The legs look like an A because the ACA hits the legs. The arms and the mouth, they look like an M because when MCA is affected, there is going to be upper limb deficits and also aphasia and face deficits. And eyes, you can see it looks like a P, and they cause left homonymous hemianopsia. They are showing because of the PCA getting affected, just like we had discussed. There are some miscellaneous strokes that we'll discuss before moving to the brainstem stroke. So pure motor stroke is because of infarct in the internal capsule mainly. So as you can see in this image here, we have the middle cerebral artery. And from the middle cerebral artery, we have these small branches which are called as lenticulostriate artery. These are responsible for supplying the internal capsule here. So whenever these lenticulostriate arteries are affected in a lacunar stroke, this would be a pure motor stroke because you have motor tracts crossing through the internal capsule. And the symptoms will be, there will be contralateral paralysis of the face, arm and leg. But there would not be any sensory or cortical signs like aphasia or neglect or visual field loss. So if you have just contralateral paralysis of face, arm and leg altogether without any sensory or cortical signs like aphasia, neglect, visual field loss, you are looking at pure motor stroke. The risk factor for this would be hypertension leading to microatheroma and lipohyalinosis. Coming to pure sensory stroke, the cause of this would be infarct in the thalamus, in the ventroposterolateral nucleus of the thalamus. Now thalamus, we know, is where all the sensory tracts are coming from. So the symptoms are going to be contralateral sensory loss now of the face, arm and leg, and again there would be no motor or cortical signs, and the risk factor would again be very importantly for any stroke, hypertension is a most important risk factor. Moving on, we'll now discuss about the rule of 4. So hang in there folks, we are done with the cortical strokes. We're coming to the dreaded brainstem lesion. If you know this rule of 4, it will make brainstem stroke localization feel almost like a game. And it's very easy. So we know that there are 12 cranial nerves. So according to the rule of 4, there are 4 cranial nerves that originate above the pons. Olfactory, optic, oculomotor, trochlear, they originate above the pons. Out of this, olfactory and optic arise outside the brainstem. So let's throw them out. So in the midbrain, you are left with 2 cranial nerves, oculomotor and trochlear. Then there are 4 cranial nerves in the pons, as you can see, trigeminal, abducens, facial and vestibulocochlear. Then we have got 4 in the medulla. So you have got glossopharyngeal, hypoglossal, vagus and accessory. These are localized in the medulla. So 4 above the pons, out of which 2 in the midbrain, 3 and 4. 4 cranial nerves in the pons and the last 4 are in the medulla. Now you have to look if they are divisible by 12. So if you look at the number 3, 4, 6, 12, all these cranial nerves, these numbers are divisible by 12. So these are located in the midline. That's the rule of 4. That if there is a midline nerve like 3, 4, 6, 12, they divide by 12, they are supposed to be located in the midline. Whereas the nerves 5, 7, 8, 9, 10, 11, these do not divide by 12. So these are the lateral nerves. With this in mind, let's move to the next part of this rule of 4, which states that there are 4 midline structures. They all begin with M and they are medial. For example, we have the motor pathway, which is also known as the corticospinal tract. So if this is going to be affected, there will be contralateral motor deficits. It starts with an M, it is medial. Then we have medial lemniscus. You must have heard of dorsal column, medial lemniscus pathway. If this is affected, there will be loss of vibration, proprioception, and light touch. Then next up, we have the medial longitudinal fasciculus. This is responsible for horizontal conjugate gaze. For example, you have to look at something on the side. Let's say on the right side you want to look. Both the eyes will look towards the right side to gaze at something. So this is your horizontal conjugate gaze. And a lesion here leads to the infamous internuclear ophthalmoplegia that we see commonly in the multiple sclerosis, right? So when MLF is affected, it leads to internuclear ophthalmoplegia. Lastly, we have the medial cranial nerves, which you've already seen, 3, 4, 6, 12. They are all medial. Next up, there are 4 structures to the side. They begin with S and therefore they are on the side or laterally. So we have the spinocerebellar pathway, which when affected will cause ipsilateral ataxia and dysdiadochokinesia, which would be difficulty with rapidly alternating movements, dysdiadochokinesia. Then we have the spinothalamic pathway. If this is affected, your crude touch, pain, temperature, these will be affected. Then we have the sensory nucleus of cranial nerve 5, trigeminal, which is responsible for sensory distribution of the face. And lastly, we have the sympathetic pathway, which we know if it is affected will lead to Horner syndrome, which is constituted by, very good, ptosis, meiosis, and anhydrosis. So these are all S structures and they are to the side or laterally. Now let's play the game. We have seen the rules. Another thing to remember is that tracts, they cross. If any tract crosses over, the symptoms of that tract are going to be on the opposite side of the lesion. So if the infarct is on the right side, if this tract crosses over, you'll see symptoms on the left side. Whereas the cranial nerves that we saw, the 12 cranial nerves, they supply the same side only. So it will lead to ipsilateral findings. So whenever you get a question about stroke localization, look for gross deficits and crossed signs to make sure that you're dealing with a brainstem stroke. Now what you'll do? Let's say in the question they give you, the patient has facial paralysis. Now facial paralysis, usually they'll give you the lower motor neuron lesion because which means that there will be no forehead sparing in this case. Whenever there is upper motor neuron, there is usually forehead sparing due to dual supply whenever there is upper motor neuron lesion. So let's say they'll give you this facial paralysis, you know it's a lower motor neuron lesion and it's cranial nerve 7, right? They can also give you lacrimation being affected because that is also by the cranial nerve 7, or salivation, or taste from the anterior 2/3 of the tongue, which is via the chorda tympani from cranial nerve 7. Now cranial nerve 7 means that the lesion must be in the pons. So the lesion is in the pons, you know this much now. Now cranial nerve 7, is it divisible by 12? No, it's not. It's not divisible by 12. So we are dealing with a side structure or lateral pons. So here we are in the lateral pons. Now one thing to remember is that facial nucleus symptoms are very specific to anterior inferior cerebellar artery. So facial flop, Aika took a drop. Just remember it like that. Another thing, check out the spelling of facial. If you spell it backwards, it will become A-I-C-A or Aika. So whenever you see any facial deficits specifically, you can localize it to lateral pons, and this will give you that the vessel that is affected is anterior inferior cerebellar artery. Now another clue, vestibular nucleus, cranial nerve 8. They can give you symptoms like vomiting, vertigo, nystagmus. This one is not very specific, but if you look at it, cranial nerve 8, it also falls in the pons. So you again know that you are dealing with pons and 8 is not divisible by 12, so it is lateral pons. What if they give you in the question, pain and temperature sensation of the contralateral body is affected? You immediately think, okay, that is carried by spinothalamic tract, which starts with an S. It's a side structure. So you are dealing with something on the side or laterally. They could give you Horner syndrome. Sympathetic fibers, you are thinking. Again, starts with an S to the side and it is going to be lateral again. Now, moving ahead, they can give you, what if they give you a patient with difficulty speaking and swallowing? So there is dysphagia and there is hoarseness given to you. Or they could give you the patient's gag reflexes impaired. You have to think about nucleus ambiguous. Nucleus ambiguous, from where you have cranial nerves 9, 10 and 11. So 9, 10 and 11 are all lying in the medulla. And you know that none of these are divisible by 12. So you're dealing with lateral medulla for sure. And in lateral medullary syndrome, posterior inferior cerebellar artery is affected. So we had already seen the lateral pontine syndrome in which ICA was affected, and in lateral medullary syndrome, pica is affected. You can remember it as Pikachu also. Pika can't chew, or in this case can't swallow, but you get the idea, right? So Pikachu. So if you find any swallowing deficits, any dysphagia, any hoarseness, you localize it to nucleus ambiguous and you know that your pica is being affected, and this is lateral medullary or Wallenberg syndrome. You can see that the other things that tell you that it is lateral are also given, like the spinothalamic tract, S structure, so to the side or laterally. Similarly, spinal trigeminal nucleus, the and the spinocerebellar tract is going to be affected. So spinocerebellar tract also you have seen, so lateral or to the side. So lateral medullary, which is supplied by the posterior inferior cerebellar artery, pica here. Okay. Lastly, what if they give you a question in which there is tongue deviation? Tongue deviation means you are immediately thinking about, hopefully, hypoglossal nerve, which is cranial nerve 12. Now, cranial nerve 12 divides by 12 smoothly. So, you know that this is located in the medulla only. It's the last number, so it's in the medulla. And it must be medial because it's divisible by 12. So, we are dealing with medial medullary syndrome. And whenever medial medullary syndrome is given to you in the question, they'll give that the corticospinal tract is being affected. They'll give you contralateral paralysis of the upper limb, lower limb. And they'll also give you ipsilateral hypoglossal dysfunction. And remember, the tongue licks the wound. So the tongue is going to deviate towards the side where the lesion is located. So if the lesion is on the left side, there will be wasting of the left side of the tongue. There will be wasting of the left side of the tongue, and the tongue will deviate to the left side only. So, to summarize it all about the anterior spinal artery or the medial medullary syndrome, they'll give you tongue deficit. They'll say that one side of the tongue is getting wasted and it's deviating towards this side. Also, they could give you vibration, proprioception, light touch loss, because that would be medial lemniscus. It's an M structure, so it's going to be medially. They could give you contralateral paralysis of upper and lower limb. So you know that, okay, this is a motor tract. Motor starts with an M, corticospinal tract is motor tract. So it must be medial. To tie it all together, tongue flops, limbs drop. Why did the tongue flop? Because the hypoglossal nerve was affected. Why did the limbs drop? because of the corticospinal tract being affected. That's how you know that you're dealing with medial medullary syndrome. Very easy. If you look at the anterior spinal artery here, this is the, in green I have highlighted here, anterior spinal artery. You can see how it is taking the shape of an M. So anterior spinal artery is the one that is knocked out in medial medullary syndrome. Okay. Now, let's not forget about the infamous locked-in syndrome, in which the patient is conscious but they'll be unable to move or speak because there is damage to a huge territory of the basilar artery. So there is, it will knock out pons, medulla, lower midbrain. So the patient will be quadriplegic. There will be no limb movement. There will be loss of facial, mouth and tongue movements also. The only thing that is going to be preserved importantly is the horizontal movement is also going to be gone. Only the vertical movement will be left. So if you have a question, patient is having only vertical eye movement, you are dealing with the locked-in syndrome. And the consciousness of the patient very sadly is maintained in such a patient because their reticular activating system is actually intact. Right? So because the RAS is intact, they are actually conscious. Now, let us go back to that question that we were dealing with. In this, a 76-year-old woman is brought to the ED with complaints of sudden vertigo and difficulty swallowing. So as soon as you see the difficulty swallowing, you capitalize on that, right? Because you know, difficulty swallowing means you're dealing with nucleus ambiguous, which is cranial nerves 9, 10. So you know it will localize to the medulla. 9, 10, 11, 12 are all in the medulla. This is not divisible by 12. So not divisible by 12 means side or lateral medulla. Now in this question, if you read ahead, we'll find that her vitals reveal a blood pressure of 160/90 and the pulse of 80 per minute. And it's regular. On examination, she's alert oriented and she's having decreased pain and temperature sensation on the left side of her face. Now remember, cranial nerves do not cross. And she is having temperature sensation being affected on the left side of her face as well as the right side of her body. The right body sensation is lost. Right-sided body sensation is lost, which means spinothalamic tract which crosses over. So the lesion is definitely left lateral. In the left lateral medulla, we can localize the lesion. And there you have it, friends. This is how we play the game of localization. Thank you so much for tuning in with us today. I hope you found this session extremely useful and now have a much better understanding and confidence to tackle this topic. If you're looking for more in-depth guidance and tips, please check out our website, thematchguy.com. It's a platform dedicated to helping med students and also medical graduates. We simplify complex concepts, distill the content for you, and provide personalized support. We are all about supporting and helping you achieve your dream match. So if you're preparing for USMLE or your residency applications, you're in the right place. Thank you so much once again. And until next time, keep working hard, keep learning.